Mechanical ventilation basic principles. Mechanical ventilation is the delivery of mechanically generated breaths via an artificial airway, endotracheal tube, or tracheostomy. The main purpose of mechanical ventilation is to deliver a breath that gets oxygen in and carbon dioxide out, thereby improving and/or maintaining adequate alveoli oxygenation, improving and/or maintaining adequate ventilation, and to decrease the work of breathing for the patient. The main indications patients require mechanical ventilation for are general anesthesia, respiratory failure, including hypercapnic and hypoxic respiratory failure, airway protection, patients with respiratory depression, drug overdose or cerebral injury causing decreased level of consciousness, patients with airway obstruction, chest trauma such as flail chest, pneumothorax, hemothorax, neuromuscular disease such as spinal injury, Guillain-Barré syndrome, cardiac failure, and control of ventilation such as for intracranial pressure management. It is important to develop an understanding of why your patient is ventilated, as this will help you to understand the modes and settings appropriate for them. Normal lungs create gas flow through negative pressure. When we take a breath in, our chest will expand and our diaphragm fall. This works to suck air into our lungs through the mouth, nose, and trachea. Modern ventilators do the opposite. They use positive pressure to push air into the lungs. But in fact, the first mechanical ventilators were negative pressure ventilators, called iron lungs. These ventilators worked by pulling the chest outwards, forcing the patient's lungs to expand, drawing air into the lungs, and then allowing the chest to collapse and air to be exhaled. This is similar to normal physiological ventilation, but the patient needed to be heavily sedated and may have a lot of complications, so it's rarely used now. Although negative pressure ventilators still exist, modern-day ventilators are almost always positive pressure ventilators. Positive pressure ventilators work by pumping a mixture of air and oxygen into the patient through an endotracheal tube or tracheostomy, which is then passively expired. This process facilitates gas exchange. When we mechanically ventilate a patient, we pump gas into the lungs to facilitate gas exchange. Gas exchange is the process of getting oxygen into the alveoli and removing carbon dioxide from the capillaries. Gas exchange occurs in the lungs between the alveoli and the capillaries. During inspiration, oxygen moves from the alveoli into the capillaries. At the same time, carbon dioxide in the bloodstream moves into the capillaries and into the alveoli, where it is removed when the person exhales. When we deliver a mechanically generated inspiratory breath, gas flow travels from the ventilator through the circuit, through the endotracheal tube, through the airways, and to the alveoli. We can think of this as a tube with a balloon at the end. The tube represents the ventilator tubing, the endotracheal tube, the trachea, and major airways, whilst the balloon represents the alveoli, where gas is exchanged between the air and blood. Using this simple lung model, we can look at some of the important principles of mechanical ventilation. If we consider our balloon analogy, in order to fill the balloon, we need gas to move down the tube and into the balloon. This requires flow, volume, and pressure. However, it is affected by resistance and compliance. Flow, volume and pressure are variables that we can control in mechanical ventilation through the mode and settings we select, whereas resistance and compliance are constants that we cannot control. Resistance in mechanical ventilation refers to anything that opposes the flow of gas through the airways. Resistance is created by the endotracheal tube and the patient's own airways, as well as the chest wall and the lung itself. Increased resistance impedes the flow of gas. Compliance in mechanical ventilation is the ease at which the lungs can inflate. Increased compliance means that the lungs are more easily inflated, whilst decreased compliance means that the lungs are stiffer. We're going to discuss the variables that we can control: flow, volume, and pressure. To move gas, we need flow. For flow to occur, there needs to be a pressure gradient, i.e. the pressure at one end of the tube needs to be different to the pressure at the other end. When we blow up a balloon, we apply pressure at the tube end and gas flows into the balloon until the pressure there exceeds that which we can deliver. When we mechanically ventilate someone, we generate a pressure at the endotracheal tube that exceeds the pressure in the alveolus, so air flows into the lungs. The flow will be affected by the resistance in the airways. Consider the different resistance generated by blowing through a tiny straw versus a big garden hose. This flow creates the volume of the breath. The volume of breath is a function of the rate of flow and how long we allow the flow to continue. Therefore, volume is equal to the flow of gas times time. The volume will be affected by how stiff the balloon is. The compliance. Consider the difference experienced blowing up a new balloon compared to one that has become stiff because it's old or damaged. Pressure is the force generated by the movement of air in and out of the lungs. It is a function of many things: how much flow we are creating, how resistant the airways are to that flow, the volume of breath we are delivering, and how stretchy the alveoli are. It is important to note that airway pressure and alveolar pressure may not be the same. This is important as our ventilators tend to only measure airway pressure, and we use this as a surrogate for alveolar pressure. Airway pressure is a function of the flow of gas into the lungs times the resistance created by the endotracheal tube and the airways. At the alveolus, pressure is determined by the alveolar volume, how much space there is to fill, and the compliance of the alveolus, how resistant it is to stretching or expansion. We want to limit the alveolar pressure to make sure that we do not damage the lungs, burst the balloon. As you can now see, flow, volume and pressure are all interrelated. These variable controls are how we deliver a mechanical ventilation breath. They are continuously displayed on the ventilator screen so that we can monitor each variable and assess their relationship. We've covered some of the principles involved in moving air in and out of the lung. Now let's look at how the ventilator achieves this. There are 3 phases of breath delivery the ventilator can control when mechanical ventilation is used on a patient. The limit, that the ventilator cannot exceed during inspiration. The trigger, where the ventilator knows it's time to deliver the breath. The cycling off criteria, when the ventilator stops assisting the breath and passive expiration begins. The main control we want to set on the ventilator is if we want the ventilator to target a set volume or if we want the ventilator to target a set pressure when delivering a mechanically ventilated breath. A set volume will generate a variable airway pressure depending on resistance and compliance, whereas a set pressure will generate a variable volume depending on time, resistance, and compliance. These control variables will be discussed further in the next lecture, Mechanical Ventilation, Modes and Settings. Key points. Flow, pressure, time and volume are variables we can control through mechanical ventilation. Resistance and compliance are constants that we cannot control. Flow, pressure and volume are all related.